So, shall I start?
Yes, doctor, you can start.
Good evening, everyone. So, this is myself. I'm Dr. Abhinav. I'm a pediatric and pediatric and cardiac intensivist. I work as a consultant at AIG Hospitals, Hyderabad. Uh, so today, I'll be discussing one of the most, commonly asked topics in pediatric nephrology, that is nephrotic syndrome. So much of this, the discussion will be MCQ oriented so that it's easy for you to understand and also retain the most commonly asked questions about nephrotic syndrome in the NEET PG exams. So I have the roadmap for today's class. So I have divided nephrotic syndrome into three subtopics. So if you actually see the previous recall questions, 98 to 99% of the questions on nephrotic syndrome are centered around these three subtopics, such as primary nephrotic syndrome, secondary nephrotic syndrome, and congenital nephrotic syndrome. Okay. So these are the three subtopics, and it'll be mostly MCQ oriented. Okay, so let's begin the class. Okay, let's start. This is the basic thing. So this is a very basic question which is commonly asked. So which of the following best defines nephrotic syndrome in children? So you have four options here. A condition characterized by hematuria, hypertension, and proteinuria. A disorder marked by the presence of massive proteinuria and hypoalbuminemia and edema. Option C, a condition characterized by blood in the urine and swelling of the kidneys. Option D, a disorder involving excess urination and dehydration. I think it's pretty straightforward, and majority of you would answer this question. So this is the definition, right? So nephrotic syndrome marked is marked by presence of proteinuria, hypoalbuminemia, and edema. So we all know that nephrotic syndrome is the most frequent pediatric glomerular disease. Okay, so there are three important features of nephrotic syndrome. To define nephrotic syndrome, these three features are mandatory. That is massive proteinuria, which is called nephrotic range proteinuria. Very important. Then hypoalbuminemia and edema, that is swelling of the face, abdomen, and legs. So remember, so previously there were four criteria. Along with this, there was also hyperlipidemia or hypercholesterolemia, which was there in the previous guidelines. But now these are the three features, and you don't require hyperlipidemia or hypercholesterolemia to diagnose nephrotic syndrome. So this slide actually gives the evolution of definition of nephrotic syndrome. The various societies like Indian Society of Pediatric Nephrology and KIDIGO, which is a international society looking after kidney disease, improving global outcomes. That is KIDIGO group. So this is how they define nephrotic syndrome. If you look at the older definitions, the ISPN 2008 definition, so nephrotic range proteinuria, hypoalbuminemia, less than 2.5 was the cutoff. And there was also cholesterol. Look at here. So cholesterol greater than 200. So this was there in the previous older definitions, but currently, so this is the ISPN 2021 definition, and this is the KDIGO 2021 definition. So here you either have nephrotic range proteinuria, hypoalbuminemia, and edema. KDIGO even says that nephrotic range proteinuria and either hypoalbuminemia or edema. One of these is also enough. Okay. So for the sake of exams, most of the exams, they ask about these three criteria. So remember these three criteria. And one important thing, the cutoff. You have to remember the cutoff value. The previous cutoff for hypoalbuminemia was 2.5 gram per deciliter, but now it is 3 gram per deciliter. And there is no need of cholesterol levels to diagnose nephrotic syndrome. So I hope everyone is clear. So there are three important features. That is nephrotic range proteinuria, hypoalbuminemia, the cutoff is less than 3 gram per deciliter, and edema. Okay. So this is about the definition. Okay. I hope everybody is clear. So now, actually, no, before going further, there are few very important definitions you all must know. I mean, it'll be useful for the from the MCQ point of view, or also these definitions are very important whenever, like, for your practice, daily clinical practice also. So, what is nephrotic range proteinuria? Very important. So, nephrotic range proteinuria. So, whenever any case of nephrotic syndrome, the best urine sample is the first morning urine sample. So, nephrotic range proteinuria is defined as, okay, 24-hour protein. I mean, protein you define in terms of urine protein creatinine ratio. So, urine protein creatinine ratio greater than 2 grams or dipstick. So, usually, routinely, we do dipstick. So, greater than 3 plus is defined as nephrotic range proteinuria. Okay. So you can see here, how do you express the dipstick results. So if it is 3 plus or more, the it is around 300 to 1000 milligram deciliter of protein, and if it's 4 plus, it's greater than 1000 milligram per deciliters of protein. So very important, nephrotic range proteinuria. So after that, other important thing is whenever there's nephrotic syndrome, you diagnose, you start them on steroids, all of you know. So how can you say that child has gone into remission? How do you define remission? So remission is defined as first morning, okay, urine protein, first morning urine sample wherein the protein is either negative or trace, okay, for 3 or more consecutive occasions, or the 24-hour protein creatine ratio is less than 200 milligrams. So most often we don't do 24-hour protein creatine ratio, we do dipstick. So dipstick negative or trace for 3 or more consecutive occasions is complete remission. Okay. So when do you call relapse? When there is recurrence of nephrotic range proteinuria. So these are the important definitions. So nephrotic, how do you define nephrotic range proteinuria? What is remission? What is relapse? Okay. Coming to this. So 85 to 90% cases of nephrotic syndrome are steroid sensitive. Okay. Most of them achieve remission 4 weeks after starting steroids at a standard dose. Okay. So steroid sensitive nephrotic syndrome, you define it when there is complete remission after 4 weeks of initiation of prednisolone. So this is steroid sensitive nephrotic syndrome. Then so when do you call as steroid resistant nephrotic syndrome? Very important. So steroid resistant nephrotic syndrome, okay, is lack of complete remission at 4 weeks of therapy with daily prednisone. Okay. So important. So the cutoff is 4 weeks. So when there is no response to daily prednisolone therapy, okay, after initiating daily prednisone therapy for 4 weeks. So if there is no response and there is no remission achieved, it's called steroid resistant nephrotic syndrome. Okay. 1 second.
You got an emergency call? Is it okay?
No, no, no.
Yeah, you
I
can.
didn't. I just got the call. I'm not able to see my screen.
Oh,
I'm sharing it again.
yeah, yeah.
So, so are you able to see my screen?
I'm able to see, but I don't
Yeah,
know why.
yeah. Now I'm able to see.
Yeah.
Yeah.
Yeah, yes, doctor, you can continue.
Yeah. Okay. So these are okay. Sorry for the interruption. I'm really sorry. I was getting frequent calls from a particular number, from hospital. Sorry. Okay. So this first 3 slides. So these are all very important basics wherein you you define the nephrotic syndrome, and other important thing, few other important terms while managing a case of nephrotic syndrome and their respective definitions. Okay, so now let's go ahead. Okay, now next question. So you have a child with nephrotic syndrome, presents with significant edema, and serum albumin is 1.5 gram per deciliter. So we all saw in the previous slide, the cutoff is 3. So which of the following is most likely physiological mechanism causing edema in this child? So four options. It's because of decreased sodium retention by kidneys. It's because of increased intravascular oncotic pressure. Is it because of decreased interstitial oncotic pressure? Or is it because of decreased intravascular oncotic pressure? I hope all of you understood the question. So what is the reason for edema in nephrotic syndrome? So that is what the question is about. So if you look at the four options, okay, so hypoalbuminemia. So what happens? Albumin is leaking out to the urine. So why is albumin important? Albumin is a very important component of your intravascular fluid compartment, and it is responsible for creating oncotic pressure and preventing fluid seepage from the intravascular to the interstitial compartment. So albumin is there within the intravascular compartment and creates an oncotic pressure. So whenever there is albumin, it prevents the seepage of fluid from the intravascular to the interstitial. Okay. So now the albumin is decreased in nephrotic syndrome. So whenever the albumin is decreased, the oncotic pressure of the intravascular compartment decreases. What happens? Because the oncotic pressure is decreased in the intravascular compartment, fluid leaks out from the intravascular to the interstitial compartment. Okay, so what's the answer here? Decreased intravascular oncotic pressure. So let me revise some basics. So for this, you also need to have an idea of the fluid compartments in the body. So we all know, 60% of our fluid is water. So it is divided into, so extra, ECF and ICF. So intracellular fluid and extracellular fluid. And how do you divide the ECF? So you divide ECF into, anybody? You divide ECF into intravascular and interstitial compartments. Are you clear with this? So intracellular fluid, okay. Then you have ECF, which is divided into more smaller compartments, that is plasma, that is intravascular, then interstitial fluid, and the transcellular fluid. So these are very important. So these are the basics. So albumin is mainly responsible for creating intravascular oncotic pressure. So whenever the albumin levels come down, the oncotic pressure decreases, thereby causing fluid leakage. So this is the explanation. So you can see here. So this slide highlights the pathophysiology. So in nephrotic syndrome, the main pathology is because of damaged glomerular capillary membrane. So what happens whenever there is damage? There is leakage of albumin. So whenever there is leakage of albumin, the oncotic pressure comes down and there is fluid which moves out from the vascular space to the extracellular fluid, that is the intravascular. Okay. And whenever there is extravasation of fluid, you have decreased effective arterial blood volume, and this stimulates the renin-angiotensin system, which causes secondary salt and water retention and edema. So here the main thing is albumin leading to decreased oncotic pressure. Okay, so this is the reason for edema in nephrotic syndrome. Hope all of you are clear. Okay, so now let's come to the next question. So which of the following is the first line treatment for steroid sensitive nephrotic syndrome in children? So this is straightforward. I will not like to waste much time explaining this. The answer is steroids. Okay, this is a very important slide. Okay, this slide highlights the comparison between the recent clinical practice guidelines on nephrotic syndrome by the KDIGO group, the ISPN group, and the GSPN group. All these guidelines were published in the year 2021, and these are the latest updates. Okay, and while answering the questions in your exam, so the key also is prepared based on these latest guidelines only. So I would not go and describe each and every point, but I want every one of you to please I mean this will be a recorded session and it will be available for you. So this slide is very important, and I request all of you to go through this slide in detail. Okay. So I'll highlight some important, guidelines and recommendations. So, I mean, this is common by all the three groups which have described their updates and recommendations. First important thing, treatment of nephrotic syndrome, is oral glucocorticoids, and the duration, very important now. It is 8 weeks, 4 weeks of daily steroids followed by 4 weeks of alternate day. So it's like, 4 to 6 weeks, but now the majority of them give it for 4 weeks, and it's also justified if you give it for 6 weeks. So most of the times in the exam, you will not get either 4 or 6. It will be some four, that is 8 weeks total. 8 to 12 weeks will be the option which you have to opt for. So duration of therapy in steroid sensitive nephrotic syndrome will be 8 to 12 weeks, which includes 4 to 6 weeks of daily steroids followed by 4 to 6 weeks of alternate day steroids. Okay. And the dosing. So dosing, steroids for the daily therapy, it is 60 mg per meter square per day or 2 mg per kg per day. Alternate day regimen is 40 mg per meter square or 1.5 mg per kg for 4 to 6 weeks. So we already saw prednisolone is dosed either by body surface area or by weight. So once daily dosing of prednisolone is more convenient than divided doses and is associated with similar time to remission. So yeah, this point, so whenever you're prescribing steroids, it's fine. Even if you prescribe once or, in two divided doses. So there were studies which have compared once daily dosing versus the divided dosing, and the time to achieve remission has been same. Okay. Now, so coming to the next question. What is the most likely outcome of using corticosteroids as a first line therapy for nephrotic syndrome in children with minimal change disease? Okay, so we all know nephrotic syndrome, most common cause, okay, that is the histological subtype. Most common histological subtype of steroid for nephrotic syndrome in children is minimal change disease, and which is steroid sensitive nephrotic syndrome. Okay, so most of the times, this subset, that is a minimal change disease, there is remission is achieved. We already discussed in the previous slide. Very steroids are highly effective in treating nephrotic syndrome, and most of them achieve remission within 1 to 4 weeks of starting daily steroid therapy. So this is one of the most commonly asked question. Okay, so we exactly do like they may ask this question in multiple formats. Okay, it has been asked so which of the following is most likely outcome of minimal change disease? There's also been a question where they've asked which of the following is the most likely outcome of focal segmental glomerular sclerosis. So if it's minimal change disease, 85 to 90% is steroids sensitive, attaining complete remission within 1 to 4 weeks. If it's so FSGS, most often it is steroid resistant nephrotic syndrome. So remember the difference. Minimal change, steroid sensitive. FSGS subtype is steroid resistant. Okay. So, so therapy with prednisolone results in complete remission of proteinuria in 85 to 90% of the patients, which is known as steroid sensitive nephrotic syndrome. While the outcome in patients with sensitive patients is satisfactory, approximately 50% show frequent relapses or steroid dependence, and 3 to 10% show late steroid resistance. So they are steroid sensitive to begin with. then later they end up as steroid resistant. Okay. But most of the times, 85 to 95%, it is steroid sensitive. Yeah. So this is one of the recent question which was asked, I think somewhere in the year 2021 or 2022. So what is the mechanism of action of steroids in treatment of nephrotic syndrome? So inhibition of renin-angiotensin system, reduction of glomerular permeability and proteinuria, enhancement of kidney filtration function, and suppression of immune-mediated damage to glomeruli. So we saw in the pathophysiology slide. So it is what happens in nephrotic syndrome. It is due to mainly it's a glomerular disease. There is disruption of glomerular membrane. So there are no exact reasons. Most of the studies have shown that. I mean, the most important action the steroids act by is by reducing the glomerular permeability to proteins, thereby decreasing the albumin spill and helping control edema in nephrotic syndrome. So this is the answer. So the best option here is by mainly their target is by acting on glomerulus and wherein they reduce the glomerular permeability. So this is how the steroids act. Okay. Yeah. So, so please go through this question. So you have a 7-year-old child with nephrotic syndrome. So now till the last slide, we saw about steroid sensitive nephrotic syndrome and a treatment. Now we'll see how you manage a child of steroid, I mean, dependent or frequently relapsing nephrotic syndrome and steroid resistant nephrotic syndrome. So this is a 7-year-old child who experiences relapse after 6 months of remission. Okay. The child is responsive to steroids. Which of the following is the most appropriate next step in the management? Start a high dose of prednisolone, continue for 6 months. B. Administer IVIG. C. Increase the dose of prednisone to 2 mg per kg for 4 to 6 weeks and start cyclophosphamide therapy. Okay. So now this child is a nephrotic syndrome who has experienced a relapse after 6 months of remission on maintenance steroids. Okay. So now, how do you go about with this question? So if you look at the option A, start a higher dose of prednisolone, continue for 6 months. So it's not like that. So you cannot continue steroids for 6 months at a higher dose, right? You all know steroids come with costly side effects. So that is definitely wrong. And B, IVIG, that's not there at all. There is no role of IVIG in nephrotic syndrome. And third is increase the dose of prednisolone to 2 mg per kg per day for 4 to 6 weeks. And D is start cyclophosphamide therapy. Yeah. So here the answer is increasing the dose of prednisone to 2 mg per kg per day for 4 to 6 weeks. Okay. So now it's very important here. So frequent relapsing and steroid dependent. When do you give steroids and when do you not give steroids? So these are the recommendations from the guidelines which we just saw in one of the slides. So whenever there's a relapse, what you do is you start them on uh, oral prednisolone as a single daily dose at 62 mg per kg per day until the child is in remission. So whenever we define remission, we do it only when remission is there for 3 or more consecutive days. So once he has achieved remission, you put them on oral steroids, alternate day steroids for around 4 to 6 weeks. So this is in relapse. Okay. Suppose if this child, okay, is relapsing frequently, then what you do, you don't stop alternate day steroids after 4 to 6 weeks. Instead, after giving alternate day steroid for 4 to 6 weeks, you put them on low dose steroids, that is around 0.5 mg per kg per day, for a few months. Okay. So this is in those in whom you have no glucocorticoid related side effects. So once again, I'm repeating. First, whenever there is a relapse, you put them on daily steroids until there is remission, that is 2 mg per kg per day. And once remission is achieved, 4 to 6 weeks of alternate day steroid therapy at 1.5 mg per kg per day. This is the treatment of relapse. Okay. But if this child is frequently relapsing or steroid dependent, okay, without any glucocorticoid toxicity, instead of stopping the steroids after giving alternate day for 4 to 6 weeks, you put the same child on low dose alternate day steroids, that is 0.5 mg per kg per day, to prevent further relapses. Hope you're clear with this. Okay. But in case, any case of steroid dependent nephrotic syndrome, once there is glucocorticoid toxicity, you have to go for steroid sparing agents. Okay. So this is another important recommendation for children with frequent relapsing nephrotic syndrome who develop serious glucocorticoid related adverse effects. Okay. And for steroid dependent nephrotic syndrome, glucocorticoid sparing agents are to be prescribed. Okay. This is important. So steroid dependent nephrotic syndrome. So steroid dependent. So remember D. So here the main focus is on D, dependent. So what are the drugs? First line, cyclophosphamide or levimazole. So steroid dependent nephrotic syndrome with glucocorticoid toxicity. There are two drugs which we have, either oral cyclophosphamide or oral levimazole. Okay, so these are the two therapies which are available. These are the first line agents. So the dose of cyclophosphamide 2 mg per kg per day for 12 weeks. Okay, very important. Cyclophosphamide should not be started until the child has achieved remission with steroids. And whenever you're giving cyclophosphamide, you have to monitor weekly CBCs, okay, because they have the tendency to cause severe leukopenia. Okay, very important. Side effect of oral cyclophosphamide is severe leukopenia. That is why weekly CBC monitoring is important. And with oral levamisole, so you also monitor here for CBC every 2 to 3 months. And other important thing is you have to check the LFTs. Okay, very important. So yeah, I just discussed. So can any one of you answer this? So which medication is the most commonly used in management of steroid-dependent nephrotic syndrome in children? Cyclophosphamide, tacrolimus, mycophenolate mofetil, and prednisolone. So the answer is N. So the answer is cyclophosphamide. We just saw. So if at all I'm going fast, please interrupt me. And if at all there are any doubts, you can stop me, and I'll be happy to clarify. Okay, shall I go further? Shall I go ahead? Okay, yeah. So this MCQ was asked in one of the AIMS entrances in the recent AIMS. So the underlying pathophysiology of steroid-dependent nephrotic syndrome is most commonly related to immune complex deposition, podocyte injury and dysfunction, vasculitis, and glomerular hyperfiltration. So remember, so it is a glomerular disease, and the majority of the if you see majority of the studies, they have described nephrotic syndrome as a podocytopathy. So underlying pathophysiologic feature is podocyte injury and dysfunction. We know that podocyte is a part of glomerulus. So the basic pathophysiological feature is podocyte injury and dysfunction. Okay, so this is how, so this slide again you can see here. So in nephrotic syndrome, if you see, there are structural and physiochemical alterations in the glomerular capillary wall, which leads to increased permeability of albumin, leading to spill out of protein in the urine. So when you look into the electron microscopic view, this alterations happen in the podocyte function. So that is why nephrotic syndrome is a podocytopathy. Remember this. Okay. So podocytopathy. So here the answer is podocyte injury and dysfunction. Okay. Okay. So till now we have discussed about most frequently asked topics centered around primary nephrotic syndrome. Now we'll look into some important things which you must know about secondary causes of nephrotic syndrome. So, which of the following is a common secondary cause of nephrotic syndrome in children? A. Minimal change disease. B. FSGS. C. SLE. D. Diabetic nephropathy. So, I think very easy here. You can rule out options. So, it's not A or B. They are primary causes. So, it should either be between C or D. So, in children, which is more common on C or D? SLE is common, right? You see, SLE is more common when compared to diabetic nephropathy. So, the answer is SLE is one of the common secondary causes of nephrotic syndrome in children. Okay. So again, which of the following is a secondary cause of nephrotic syndrome that is linked to an allergic reaction? Okay. A. HSP. B. Allergic rhinitis. C. Atopic dermatitis. D is allergic bronchopulmonary aspergillosis. Yeah, if you carefully read and try to exclude the options, you will be able to answer this question. So I asked you about secondary cause that is linked to allergic reaction. So first option, HSP. So do you think it's an allergy? It is related to allergy? No, it's a vasculitis. So this is unlikely. And allergic rhinitis and nephrotic syndrome doesn't happen. And atopic dermatitis and nephrotic syndrome is also a rare entity. So what could by exclusion you can come to a conclusion that D is the best option here. Okay, so the answer is D. Yeah. So ABPA can lead to secondary nephrotic syndrome, typically in context of chronic allergic reactions. So ABPA results from hypersensitivity to Aspergillus species, and it may cause glomerular damage leading to nephrotic syndrome. So remember this. This unless until you go through the entire table of secondary causes, you will not be able to answer this. So even ABPA, remember this, ABPA is linked to cause nephrotic syndrome. Okay, I think this majority of you all will be answering this. So secondary cause of nephrotic syndrome that is most commonly associated with viral infection. So which virus among A, B, C, D? So B is not virus, so it is among A, C, or D. So which one? So the answer is yeah, HIV. So HIV related nephrotic syndrome is known as HEBAN. So HIV associated nephropathy. So this is from the Nelson textbook. So you have to remember these secondary infections. I told you Hep B, C, HIV, malaria, toxoplasmosis, syphilis. Okay, these are the common viruses. And if someone asks you which is the most common infection causing nephrotic syndrome, if the option is malaria, I think you have to choose malaria of the option. Okay. Then drugs, gold, NSAIDs, interferon, lithium, and malignancies, lymphoma, leukemia. Remember, you also have to remember Wilms tumor. You have syndromes associated with Wilms tumor and nephrotic. So even malignancies can be associated with secondary nephrotic syndrome. We saw this. Other miscellaneous causes, diabetes, SLE, IgA nephropathy. Okay. So which of the four now? Which of the following is a secondary cause of nephrotic syndrome in children that may result from a malignancy? I want one of you to, volunteer and answer this. So, A, Wilms tumor, B, neuroblastoma, C, leukemia, and all of the above. I think we just saw in the previous slide. I also highlighted one very important point. Okay, so the answer is all of the above. Okay. So these cancers, they cause nephrotic syndrome through various mechanisms such as immune complex deposition or direct invasion of the kidney by tumor. Yeah. So these are this is about most important things which you must be knowing about secondary cause of nephrotic syndrome, and I think I've mostly covered in all the questions which I've put in the slides. So this is very important table you have to remember. I hope after this class you people go back and memorize this table, because once you memorize this table well, you will be able to answer all the questions. So now, most important subtopic, and which
Doctor,
is
sorry to interrupt. Actually, this is not a pro version, so we have less than a minute. Uh,
yeah.
so can we end this?
Yeah, okay. So this again, congenital nephrotic syndrome is one topic which is being asked very commonly. So about congenital nephrotic syndrome, this is important slide. You need to know about the common genes associated and the syndromes associated. So the most common gene mutation which is associated with nephrotic syndrome is NPHS1 gene, that is the nephrin gene, which causes Finnish type of nephrotic syndrome. Okay. And NPHS2 gene mutation, it is the second most common cause, which often leads to steroid resistant nephrotic syndrome, that is FSGS type of nephrotic syndrome. And with regards to inheritance pattern of congenital nephrotic syndrome, they are inherited in autosomal recessive manner except for LAMP2 gene mutation, which is inherited in X-linked recessive manner. Okay, remember, most common is autosomal recessive. And two important syndromes with congenital nephrotic syndrome is Dennis-Drash